Hello, I want to start my talk by first thanking the organizer of this 12th Liver Summit to give me the opportunity to give a presentation to our Pakistani colleagues. The topic of my talk is HDV current therapy and emerging frontiers. These are my disclosures. This is the outline of my talk. I will start with current treatment. I will mention prepeginterferon shortly, bulevirtide in detail, nucleus analogs very shortly, and then switch over to new treatments where I'm going to mention monoclonal antibodies, small interfering RNAs, and nucleic acid polymers. So current treatment, I will start with interferons. As I said, I'm not going to give a resume of interferon studies. There are many of these, but mention the two largest studies, and these were randomized controlled clinical trials and are important in that context as well. These are the two studies which highlight a very good collaboration between my center at Ankara University Medical School and Harvard Medical School, headed by the late Michael Manns and later on by Heiner Wedemeyer. In the first of these, peginterferon alpha adafovir combination was compared to peginterferon monotherapy versus adafovir monotherapy. The first result of the study was that the expected result that the peginterferon arms did better than the adafovir arm. Adafovir had absolutely no effect on treatment response. However, peginterferon adafovir combination was not superior to monotherapy arm. That was the other result. Despite this, there was one thing to be added, and that was that peginterferon in the peginterferon combination arm, quantitative surface antigen levels with a decrease of more than 1 logs was more evident with combination treatment than with monotherapy. Therefore, we decided to do a second study. We want to use a more efficient nucleotide molecule, and that is tenofovir compared to adafovir, because remember, adafovir was used at the suboptimal dose because of nephrotoxicity. So a more efficient nucleotide analog in combination with peginterferon, we want to see if that would lead to a more evident response in terms of surface antigen levels. And also we want to see if 2 years of treatment is better than 1 year of treatment. So we will try to kill two birds with one stone. The result of the second study with peginterferon showed that 2 years appeared to be better than 1 year if you look at the end of treatment response, 47 versus response rates in the 30s at end of less than 40% with both arms. But then after stopping treatment, this difference went away absolutely. However, in terms of combination arm and monotherapy, there was no difference. But if you look closely at the end of treatment, 47% HDV RNA decline versus HDV RNA response, and this is percent HDV negative, not 2-log decline, versus 33% HDV RNA negative. So there's a 14% difference. But this, again, goes away after stopping treatment. But I will come back to this when I talk about nucleus analogs. And then we at Ankara and they at Hanover did two separate studies where we both assessed the long-term benefit with HDV RNA suppression. The Hanover group showed that interferon treatment is better than no therapy or nucleus analog on the long term when you had follow-up of 20 years. These two studies were based basically on the databases of the two centers. And we did a similar study, but we checked only patients with interferon treatment, because we thought that this is a more homogeneous group in which we compared patients who had a maintained virus response, which we define as to have undetectable HDV after 2 years of stopping treatment. Since they did this one study has shown that treatment while relapse is possible, while rebound relapse is possible after post-treatment 6 months in a sizable proportion of patients. So we used a 2-year period to decide whether we have a viral response or not. And we compared that with patients without maintained virus response, and the outcome was that patients with maintained virus response had a much better long-term survival, and patients without maintained virus had a higher rate of liver-related mortality, as shown in the green line. Despite having the data on 2 years, interferon is no better than 1 year of interferon with the HDV1 and HDV2 comparison, and also based on anecdotal pilot studies with 2 years of interferon. We were convinced, and based on our and also some studies from the NIH and so on, that there are some patients who benefit from prolonged treatment, and therefore we want to see if that's indeed the case. And we checked our database and saw that there were some patients, even patients who received a total of more than 10.5 years of interferon. And then they were HDV negative. And actually this 10.5-year patient with 10.5 years, similar to the patient from the NIH who received 12 years of interferon, cleared surface antigen as well. So anyway, there were some patients who benefit, not all, but some patients who benefit from prolonged treatment. And this, after 5 years, for example, of interferon, 50% of these patients had responded. Another thing which I want to say, that those patients who had the maintained virus response 2 years after treatment, around 35% became surface antigen negative on the long term. So if you need to treat patients still today with interferons, you have to try to do the best in terms of assessment of the patients and try to use state-of-the-art instruments to assess if the patient is responding or not. And therefore, I wouldn't do a study with interferon without looking at HDV on treatment and without looking at quantitative surface antigen levels, baseline and on treatment. Although this is not an easy thing to do in a country like Turkey, where we don't have quantitative surface antigen tests available in state hospitals, state universities, but have to depend on private labs. And not many of them have quantitative surface antigen level testing. Although this is more or less routine in the Western countries, except the US, I have to say. So try to have quantitative levels also measuring when you do a study with interferons or with any drugs nowadays, baseline and on treatment, because what we have shown is that the best predictor of treatment response was by multivariate analysis, HDV on treatment HDV levels. And if you have by area under the curve Yurdaydin index, an HDV level of 2.5 logs, a decrease of 2.5 logs, or an HDV level of 2.5 logs was associated with the treatment response post-treatment. So if you have a decline of more than 2 logs of HDV compared to baseline, this is a very good sign that you will have a post-treatment response. So, and if you engage with a study where you treat patients with interferon, please check not only this study by Keskin et al., but also Nero et al. By APNT 2016 and Salman et al. By Pathology Communication 2022, because you could see also useful information in terms of quantitative and in all 3 of these articles. So basically, on treatment, quantitative surface levels around 3 logs is a good sign that the patient is going to respond. And if you can check correlate antigen, which we cannot do in Turkey, you can also use that based on the study by Lisa Salman et al., which describes in detail how you can use you can use data on correlated antigen. Now, coming to nucleoside analog in chronic hepatitis delta, I want to mention the recommendations made by the EASL Guidelines Committee, and these reads as following. Nucleosome should be given in patients with decompensated cirrhosis, irrespective of the presence of detectable HBV DNA. That's number one. And in patients with compensated cirrhosis, patients with detectable HBV DNA should receive nucleosome analogs. In non-cirrhotic chronic hepatitis delta, if the DNA is more than 2,000 international units per ml. These all three recommendations are based on strong recommendations and are based on strong consensus. But none of these recommendations are based on are evidence-based. The only thing I can say that is there are studies which is in favor of using nucleosome analogs for treating HPV patients who have elevated HPV DNA, because early studies from the 90s from Italy, for example, from Rizzetto's group, has shown that patients who have both high DNA, HDV and HPV DNA are more prone to have significant liver disease, serious liver disease, and therefore it makes sense to decrease HPV DNA levels in these patients. But other than that, there's no evidence. And I'm going to show you the first evidence that suggests that there is room for nucleosome analogs in the treatment of delta hepatitis, and that is the study, 10-year follow-up study of 82 study. And again, this is a randomized controlled study, and it is important in that context. The study has shown that after 10 years of follow-up, the cumulative event-free survival is much more worse in patients who received PEG interferon monotherapy compared to patients who received PEG interferon tenofovir. So this is the first description of a positive evidence-based effect of nucleosome analog, even not alone, but still in combination with interferon. Now coming to bulevirtide. With bulevirtide, we have a short history of bulevirtide use, but we have learned much more than we have learned with interferon throughout decades of life. Because since hepatitis B and C is done more or less, everybody was interested in delta hepatitis suddenly. And there were 3 phase 2 studies and 1 phase 3 study. And the first phase 2 study, year 202, dealt with monotherapy. And we learned a lot from this study. And we learned a lot from these 2 studies, which dealt with combination versus monotherapy. And we learned a lot also from the last study, phase 3 study, with 3 years of bulevirtide monotherapy. What we have learned is that bulevirtide is a drug which leads to HDV decline. And this HDV decline, first of all, remember, bulevirtide is an hepatitis B surface entry inhibitor. Despite this, what you expect is a decrease in its surface, and this didn't happen. But what we have seen is the secondary result is the decline of HDV RNA. And the longer you treat, the more you have a decline. The decline is more significant with bulevirtide treatment. There is no tachyphylaxis effect. There is no resistance to drug. There's no viral resistance. This is to expect because it does not work on virus factor. It does not on a virus enzyme or something like that. I'm sorry. And what you show here is this is similar to what we know from the hepatitis B studies with nucleosome analogs, irrespective if the patient, the effect on the virus and on ALT levels are similar, irrespective if the patient is cirrhosis or not. And this can be seen here with 2 and 10 milligrams of bulevirtide in patients with cirrhosis or non-cirrhotic chronic delta hepatitis. And then this study has shown that bulevirtide can also be used in decompensated cirrhosis with the first, based on the first knowledge, is that one of the first things we learned from bulevirtide studies is that bulevirtide is safe. And because it was safe, the use of it in patients with decompensated off-label use of bulevirtide is justified, provided you explain the situation to the patient. Because what we see is the efficacy and the safety things. These are separate issues. Efficacy is was seen in viral response in 67%, normality in 86%. Median MELD and child pool score were stable. There was on-treatment recompensation from child pool B to A cirrhosis, which is very good and a very good sign, a clinical good sign that you have benefit from the drug. Delisting of liver transplantation occurred. Ascites improvement occurred in 6 patients. But if you look at safety, and that's downside, and this is also to be expected in patients who have very advanced liver disease. De novo ascites formation occurred in 3 patients, worsening of ascites in 2 patients, liver transplantation was still needed in 3 patients, and there was 1 death due to acute chronic liver failure. So this is what I mean, provided you explain the situation to patients. You have to explain that the patient may benefit, which is a likely chance, but the patient may also deteriorate during the treatment, and you should give the information to the patient in that regard. Now, the first study I'm going to mention is the phase 2 MIR-202 study, which was the treatment for 6 months. And with this study, we learned actually already that this is a drug which you cannot use in the context of as a monotherapy in the context of finite treatment, but you need to treat for prolonged treatment, because after 6 months, 90% of patients after stopping treatment had a rebound in viral rebound, which was followed by a biochemical rebound. So 6 months of treatment was out of the picture. And then I want to switch gears and mention a real-world study, which I agree, which I like in some parts, but I did dislike in other parts. I like the comparison of the Bulevar 2 milligram monotherapy with the combination of PEG interferon, because this combination arm, because of PEG interferon and its immunomodulatory action, has the potential to be of a treatment duration. So what they did was they compare monotherapy with combination therapy, but they didn't look at it as finite treatment option. That's what I didn't like in this study. And because the number of patients decreased over time, not due to side effects or so, they did write the per protocol analysis of the data. So this is response over 12 months. And as you can see here, this is monotherapy and this is combination treatment. Combination treatment was far much better than monotherapy. And this can be seen also in this bar graph, where you have at 12 months, 94% versus 68% viral response, and defined as undetectable HDV or more than 2 log decline of HDV compared to baseline. In terms of undetectable HDV, it's 85 to 39% combination versus monotherapy arm. Now, but more importantly, 2 years of treatment. And when you say 2 years of treatment, you have to think that combination arm was after 1 year was divided into 3. In one group, the study, the treatment was stopped. In the others, this was continued either as combination arm or was switched to monotherapy arm. So we're dealing with, we'll look at combination versus monotherapy arm, and this is shown here. This is the combination arm after 2 years of treatment, month 24, 75, 71% viral response rate versus 68% with monotherapy. We were 68% with monotherapy. And okay. And in terms of undetectable HDV, 44 versus 37%, so similar. And they conclude that viral response increased with Bulevar 2 milligram over time. That's correct. And leading to similar response rate at 24 months compared to combination arm. This is also correct, but you give the impression that there's no difference, and there's absolutely no difference, and there is a difference. One is a combination, where one is a prolonged treatment arm, one is a finite treatment arm. And what you have not done is to see how the off-treatment response rate looked like. To say that they're similar in terms of response rate, you have to look at 6 months post-treatment, and this is not done here. And therefore, I mean, this final statement is half correct. And now this has been done in the 204 study. And this is a very important study, but I like one thing, again, not very much. And this is, look, you compare pig interferon for 24 weeks with pig interferon, 2 milligram combined with bulevirtide, 2 milligrams or 10 milligrams for another 48 weeks. This is fine. But then you don't stop pig interferon treatment, but you don't stop this bulevirtide treatment arm and continue with bulevirtide 2 milligram. So to say, to consolidation arm with bulevirtide 2 milligram and 10 milligram. I mean, who told you that you need a combination or consolidation arm? This data is not available, and therefore I don't like this planning. And then you compare it with 10 milligrams for 2 years. So this is a little bit bizarre. You try to kill with one stone, two birds, and you don't achieve that actually. So here are the data, and you can interpret how you want to like. Pig interferon after 24 weeks after end of treatment. So they did treatment for 1 year and then off treatment 1 year, and result was 25% undetectable viral response, undetectable HDV, which is fine, very good. Bulevirtide 2 milligram combination with pig interferon, 26%. Very disappointing if you compare to monotherapy with pig interferon. And then you could look for bulevirtide 10 milligram with pig interferon, 46%. Very good in terms of comparing it with 2 milligrams bulevirtide combination, and also for pig interferon. And in particular, if you compare it with 10 milligrams of bulevirtide over time, it's 12%. So, how to use this data? But to add to your confusion, so with the 10 milligram data looked very fine, and on top of that you have 4% surface antigen clearance, which is better than 0% with pig interferon or bulevirtide. Okay, but if you look for the combination with 2 milligrams, this is 8%. I mean, you have very disappointing results with bulevirtide 2 milligram combination, but suddenly with surface antigen clearance, there's hope for 2 milligram combination in arm as well. So how to interpret this? I mean, this is not unexpected, since the first study was actually the 204 study. This was a phase 2 study. And what they did was they checked for they were 1 year of treatment with pig interferon was compared to the combination with 2 milligrams, 5 milligrams, and 10 milligrams bulevirtide with pig interferon for 1 year. And then another comparison was comparison with 2 years of pig bulevirtide and 5 milligrams of bulevirtide BID, and so 10 milligrams bulevirtide with 10 of it. I mean, this is a better design, I have to say. And this is the results of the proportion of patients with undetectable HDV at off treatment week 24. Pig interferon, 7%, not 26, 25, but 7%. And then bulevirtide 2 milligrams, 60%. I'm sorry, I'm looking at the wrong place. Off treatment response, it's 0% with bulevirtide with pig interferon, undetectable, and it was 25% with the other regime. In the other study, 53% with combination of bulevirtide with pig interferon, which is double the number of the study in the previous study. And with 5 milligram, it's 27. And with 10 milligram combination, you suddenly have only not 46%, but 7%. Of course, there's no addition of 1 year of monotherapy, but still, I mean, this is bizarre, very bizarre. And bulevirtide 2 milligrams is again 7%, and suddenly bulevirtide 5 milligram BID with tenofovir is 33% off treatment response. And this is again very bizarre. But what is not bizarre is this combination of bluvaterate with 2 milligrams peg interferon was associated with 40% of surface antigen decline by more than 1 log. And this was 0% with peg interferon, 0% with 10 milligram bluvaterate combination, 13% with bluvaterate 2 milligram and 5 milligrams BID bluvaterate was the same. So overall, it looks like that the combination with bluvaterate peg interferon at a dose of 2 milligrams appear to be the right dose in terms of looking at surface antigen response, and because surface antigen response is the ultimate goal of treatment in a final treatment arm. But you cannot say that 10 milligrams is worthless based on these two studies. But my sense is that the 2 milligram combination is the right choice. But we have to have more results. Now, in terms of this study, the 301 study, monotherapy arm, we have much better and cleaner results. In this study, we have 3 years of bluvaterate monotherapy versus 10 years of 10 milligrams of bluvaterate monotherapy, and we have the results versus 2 years of delayed treatment with bluvaterate 10 milligrams. So what they have, overall, almost 50% of patients had baseline cirrhosis, and for bluvaterate 2 milligrams, here you can see undetectable HDV RNA over time increased from 12 at 48 weeks to 29% at 3 years. So there is a steady increase of response, and this is what I meant. This is a very nice description of the data. But off-treatment response is disappointing. It goes to 18 to 16% after 1 year of off-treatment. And for 10 milligrams of HDV of bluvaterate off-treatment response is 20%. But it's after 2 years of treatment. Another very important point is that HDV RNA relapse occurred, but 93% of 38 of 41 patients who had a relapse, HDV RNA relapse, this occurred in the first 24 weeks follow-up, and the rest was occurred in the second half of the first year. 90% of patients with undetectable RNA did so for 96 weeks, maintain undetectable at week 48 of treatment. And I think that is also very important information. I will come to these informations as well. So here you can see various responses, but for the difference between 10 milligrams and 2 milligrams, you have to see not various response in the sense of 2-log decline, but you have to look at undetectable HDV RNA. But what is important is the off-treatment response. So bluvaterate is not the cheapest drug, and it's daily injection, so it's better if you can stop at some point. And therefore, we were hoping that after 3 years, 3 years is a good time to stopping treatment. And in that sense, we learn a lot. First of all, undetectable HDV RNA was at end of treatment of 3 years in 29% achieved with bluvaterate 2 milligram, and it went down to 10% at 1 year off treatment. With bluvaterate, undetectability was achieved in 50% after 3 years. It went down to 22%, and with deferred treatment, it went to 20%. So overall, 20 to 22% off treatment response, long-lasting response, and the good news is that after 48 weeks of treatment, there is no relapse that occurred, and this is also good news. So the longer duration of on-treatment undetectability predicts sustained post-treatment undetectability. This is also very useful information. So if you have a cirrhotic patient and the patient has undetectability for 2 years, you can more or less safely stop treatment, but you still have to closely follow this patient, but you have to stopping is justified, so to say. In patients who are cirrhotic, you shouldn't stop it when the undetectable rate is between 1 and 2 years, because 50% will relapse. So for non-cirrhotic chronic delta, that's a good point to stop treatment. But for the rest, before having an undetectability rate, undetectable HDV for 1 year or less, for less than 1 year, 90% will have a relapse. And you shouldn't stop with 1 year of less than 1 year of undetectability. So for stopping treatment, you should have on-treatment undetectable HDV for at least 1 year. And it's not easy to achieve that, I have to say as well. Because there are patients who have severe relapse, ALT more than 10 times the upper limit of normal in 10% of patients. So in conclusion, the study has shown that blue monotherapy maintains virologic response and biochemical response in a subset of patients. 96 weeks after stopping treatment, after 2 years of stopping treatment, this is still valid. Virus relapse occurred in over half of those patients who were undetectable at the end of treatment, occurred most often in the first 24 weeks of end of treatment. The rate of liver-related clinical outcomes while on bulevirtide and through 90 weeks of treatment was low. ALT increases after treatment discontinuation. You have to be careful, especially in patients with cirrhosis. Monotherapy is safe in patients with compensated cirrhosis, no different in viral load decline versus non-cirrhotic cases. Now, what about combination treatment? That is still a final treatment option and has to be explored further and may need to surface antigen, which is also very important. Now, coming to new treatments now. And this is very exciting and there's interesting news. Let's start with tobevibart and elebsiran. The mode of action, tobevibart is a monoclonal antibody. So it is basically hepatitis B immunoglobulin, but it's a monoclonal antibody. Targeting the antigenic loop of surface antigen. It leads to neutralization of surface antigen. It leads to less surface antigen available in the bloodstream. Elebsiran is a small interferon RNA, further tailoring surface antigen production, and leads further to surface antigen clearance and lower surface antigen levels. So with this, we have lower level of surface antigen in the bloodstream. That leads to less stimulation of the immune system by surface antigen epitopes. And before that, the immune system is overwhelmed with surface antigen epitope stimulation, and that is gone. And therefore, the exhausted immune system wakes up and has immune stimulation. And this is the second mode of action of this combination of all these monoclonal antibodies, and that antiviral efficacy combined with immunomodulatory efficacy of the wakening up of the immune system. And that has been shown in the paper published in the Journal of Hepatology separately. I want to mention this study, this phase 2 study, which paved the way for the phase 3 study, which I'm going to mention as well. The outline of the study. And in this study, tobevibart, the monoclonal antibody, was used in every 2 weeks for 96 weeks. And there were 33 patients, of whom 14 were cirrhotic. The combination arm was tobevibart 300 milligram and elebsiran 200 milligram subcutaneously every 4 weeks for up to 96 weeks. So both drugs were to 96. These were 33 patients, of them 18 were cirrhotic. And what you see is that the percentage of participants was with undetectable HDV was 100% with combination arm after 24 weeks. And this compares well to patients who received monotherapy with tobevibart, only the antibody 82% after 24 and 79% after 48 weeks. So 80% with combination, 80% with monotherapy and 100% with combination arm reached the viral response. And I'm sorry, it's not undetectable HDV, it's more than 2 log, or undetectability, because undetectability is less. You have seen 41% after 48 weeks, after 24 weeks on treatment, and this goes to 66% after 48 weeks. I'm sorry. So here's 48 weeks, and this is 48 weeks combination arm. Whereas the monotherapy arm, 24 weeks, it's 30%, it goes up to 48%. So definitely this study, I mean, both the undetectable HDV RNA measurements better shows that combination arm is better than monotherapy arm. And in terms of ALT, there's a strange picture here. It was 47% normal ALT with combination treatment at week 24 and 56% at week 48. Whereas this was, it was much better with monotherapy arm, 76%. So somehow it appears that small interfering RNA somehow increases ALT in a non-specific way. And once you stop small interfering RNA, it is likely that the ALT is going to normalize in increasing amounts. And further, an important aspect is that surface antigen levels. Combination arm, 88% after 24 weeks and 91% after 48 weeks. I mean, this is very good. With monotherapy, it's only 20%. So we have to go with, definitely with combination treatment, because not only undetectable HDV, but surface antigen levels are also important. And this is done in the ECLIPSE study. The company who's running this drug studies are quite confident, because you can see that they compared in this phase 3 study, for example, a switch to bulevirtide or comparison to bulevirtide. I mean, comparison to bulevirtide is showing confidence, but switching to bulevirtide is a strange approach, which is a negative approach, but I don't want to say anything further. But I mean, it's very good competition, I have to say. Now, another monoclonal antibody is this BGT778 company. It's another monoclonal antibody from an American company. And this has, again, an alternate modes of action. It leads to neutralization of the surface antigen, leads to decreased levels of surface antigen, and this may lead to immune stimulation, and in addition to antiviral efficacy, also antiviral immunity increases, and that's exactly what happens. But the dose used were 300 milligrams subcutaneous once weekly for 48 weeks. This was in 10 to 20 patients, compared to 600 milligrams subcutaneous once weekly for 12 weeks, and then the same dose every other week for 36 weeks, altogether again 48 weeks, compared to BGT700 900 milligram subcutaneous every other week for 4 weeks, and then monthly every week for 48 weeks, so altogether 48 weeks again. The results are seen here, but before that, again, what I said about immune stimulation is correct. As you can see, there's HBV specific T cell activity is increased significantly. In terms of viral response, I mean, first of all, 100% virologic response, not by the combination arm, because there is no combination, there's only one hepatitis B antibody already at week 44 with 300 milligrams, 600 milligrams, 900. I mean, 100 virologic response, so more than 2 log decrease is seen in every single arm of this study. And I mean, with the monthly dose of 900 milligrams, you can see that it's already at 24 weeks. I mean, similar to the combination arm in the previous study. Here we are. Where's the, okay, here. For 24 weeks, and this is done already by 16 weeks, I'm sorry. And here it's, again, very early, and with 300 milligram. It starts at 28 weeks. So this is an interesting study, and the Blue Jay Therapeutics company is the sponsor of the study. And the other Vir compound, the Vir pharmaceutical compound, is already full enrolled and done is doing the phase 3 study. This compound, the full enrollment will be done by the first trimester of this year. So we will have both data and the first year result of both data of both compounds after 1 year, and maybe also with the month 6 data in the next meetings to come. And this is going to be exciting. Now, one final monoclonal antibody, and there's a response from China. Efficacy safety of Libevitug HH003 in patients with chronic hepatitis D. It's the presentation I took. Dr. Said Hamid nicely gave it for me to present the data on his behalf to you. I'm going to use 2 slides of his. Lipitor has again a dual mode of action. Again, the similar approach, antiviral efficacy combined with awakened immune system activity. And he used 2 arms, 20 milligrams per kilogram of this compound for 24 weeks versus 10 milligrams per kilogram of this compound for 24 weeks compared to control, and another 20, so overall to 48 weeks. I mean, he decreases after 24 weeks to Q2 weeks, not weekly, but Q2 weeks, and then has a 24 weeks off-treatment response control. But I'm not going to show you off-treatment response, but on-treatment response after 24 weeks, where you have a response of 42 to 35, and this increased to 36 to 50% after 1 year. So there's an increase after 2 years, after 24 months. I'm sorry, after 24 weeks. In the second 24 weeks, after 1 year, you have an increased response, but it is viral response, and viral response is defined as 1 to log reduction from baseline and low or below the level of detection. So, and this is a little bit less compared to the previous ones. ALT normalization is fine. And we will have the phase 3 study with this compound as well, starting soon, this year. Now, final polymer for treating HPV and HDV. I mean, this drug, as you know, is the oldest drug of all this, and still, according to the result, the best one, according to the result. But it's some things cannot be explained. I cannot explain. Well, I'm going to tell you what I mean. So, these compounds were used first in a study, in a phase 2 study in Bangladesh, and this was published in the Lancet Gastroenterology Pathology in 2017. HDV negative was in 58%, in 7 of 12, and in 42% with anti-HB positivity. After 3.5 years of off-treatment, no treatment they received, HDV was still negative in 7 out of 12, so 58% were still HDV negative. Surface antigen was negative, continued to be negative in 33%, and antibody was positive in 33%. So these are response rates you can only imagine for other drugs. So these are very good response rates, by the way. And here's the latest publication of them. This is an article press in Journal of Hepatology, Safety and Efficacy of Rep 24/9-39 magnesium in patients with HDV-related advanced liver disease in an international compassionate access program. Not because the drug has been licensed in some parts of the world and we use a compassionate use program. No, It's the compassionate access program through of a drug which is less than nowhere in the world, despite having fantastic results. And I cannot find the response why they cannot find the money, raise the money to have a phase 2 or phase 3 program. Again, here you see the results. Again, very good results. I mean, out of the 33 patients, 6 they had decompensated cirrhosis, and 28 failed to one or more previous treatment regimens. After treatment discontinuation, median follow-up was 46 weeks, and 46% had a sustained biologic response, and 18% had a functional HPV cure, so they were surface antigen negative and anti-HBs positive. So fantastic results, but I mean, still nothing I can tell. Now, finally, another not old but new, not so new drug, lonafarnib. You may remember the phase 3 study, which was presented at the EASL meeting in Vienna in 23, with off-treatment response rates better than end-of-treatment response rate, but still a little bit disappointing high rate of discontinuation rate because of side effects. But whatever, what we did was to look at the phase 2 program mainly in Ankara and the NIH, and combine them with the phase 3 program in Istanbul at one center of my center in Istanbul, and look at post-treatment response to lonafarnib long-term. And we saw a long-term lonafarnib-based therapy with long-term clinical benefit, provided that they had a composite endpoint post-treatment 6 months. I mean, these treatments were for between 2 and